Here you have to play with the angles.
Today I am going to discuss the design of hairline in stage 2 and 3 male pattern baldness in young adults that are between the age of 18 to 25 years of the age. And lot of people come to us in this age and they want to have a hair transplant because of their social stigma or because of the psychosocial factors. So moving forward, hairline designing in the young adults with stage 2 or 3 normal male pattern baldness is one of the most difficult and challenging tasks because uh, it is a point because they are losing their hair and they want to have their hairline back. It requires a lot of surgeon's experience and insight in the hair loss patterns. A surgeon has to design a cosmetically and aesthetically acceptable hairline by balancing patient expectations and realities. This is a very important point, and this is a point I want to emphasize in this presentation. So now we will discuss what are the factors affecting in designing a hairline in a young patient stage between 18 to 25 years of the age. So first of all that is very much common in our society is the patient expectation. In Western countries, people don't even mind at the stage 2 or stage 3 hair loss. That what is my experience is. But in Pakistan, stage 2 or stage 3 is a very distressing and psychological stigma for the patient. Patient always want to have a straight and very broad hairline, and they always insist for it. This is a major factor in deciding designing the hairline in patients with this kind of hair loss. Our second factor that is affecting in designing the hairline in young patients is the social factors. We have a lot of patients who understand what their hairline design should be, but their relatives, their friends, they insist on a straight hairline because they think that the patient should have this kind of hairline. This is the thing that we have to also address in designing the hairline. This is what the patient expects that his hairline should be in stage 2 or 3, that is a younger patient. We have to look for the pattern of the hair loss. Although the patient might be having a stage 2 or stage 3 hair loss, but still the viable hairs present on his scalp might be very thin, or there might be a diffuse thinning of the hairs, or hair might be brittle, they might go very early. Very important, we have to examine the donor area condition. A thorough examination of donor area is very much important, as a thin donor area or reverse thinning of the donor area is a major factor in determining the hairline pattern. Very much important, family history, because family history will give you an insight how his hair loss pattern would be in the next coming years. So, what are the surgeon considerations? Surgeon should foresee what is the hair loss pattern of the patient in the next coming years. He should keep in mind what the patient look with his design when he loses the rest of it from his scalp. So this can happen if the surgeon design his hairline. The hairline would get suspended in I must say in space. So detailed counseling of the patient is very much important. This is a key factor in doing hair transplant in stage 2 and 3 male pattern baldness, because patient has very high expectations and you have to balance his expectations with the realities. So what the design should be? This is a set of I must say the rules that I have learned from the last 4 years and that I apply on the patients. So what the height of hairline should be? In young adults, the middle part of the hairline should never be in any case less than 4 finger breadth from the nasion. I take the nasion as a reference point in the young adults. I try, in most of the cases, if there are traces, I try to follow a natural hairline pattern. And if natural hairline is too low, then I ignore the hairline and make a hairline at the standard place of 4 fingers. So look at this. On the this is a patient that is 22 years of age and want to have his hairline back. I did his thorough counseling and he agrees on this design. And this is the acceptable design for his future hair loss if he get hair loss from this area. Similarly, this is the second patient he was of 22 years of age and he also want to have his hairline restored. It is very important to create frontotemporal recessions, as blunting them will give you a natural look. Look at the pattern that I have drawn. Similarly, in this patient, and always make temples with backward slanting angles within the natural margins. Never make straight or forward temples and never cross the natural margins. Look at the pattern of the temple. These are slanting backward and I have never crossed the natural margins. So always make connections. Always transplant within 1 to 2 centimeters of a normal area all around so that your hair transplant won't suspend in air. So here I have make connections over here. This part that he will lose in the immediate future, in the immediate next 2 to 3 years. So, and when we don't follow these rules, we have got a case in which some person had not followed these rules, and we have seen these much results. Look at his hairline. His hairline is too low as compared to his natural existing hairline at this stage. Similarly, look at his frontotemporal angles, the blunting of the angles, and look at his own frontotemporal angles. Look at the temples. Here somebody who has done his surgery has made a straight temples that are suspended in air and are not connected. And similarly, there were no connections. So his hairline has been suspended. So the take-home message is try to follow the nature, otherwise your patient has to bear the stigma for the whole of his life. Thank you very much.
First and foremost important thing regarding PRP is that in 2013, while I was in meeting in San Francisco, I learned that there's no any protocols for PRP in hair restoration. Still, the work is going on by different groups at different places, and no any reveal benefits even for the hair restoration. So I'm working as same you might be working, and facts will be revealed by passage of time. The history of PRP, the first introduced in 1980s for the treatment of cutaneous ulcers, especially for the diabetic patients. The use expanded in 1990s in maxillofacial and plastic surgery fields in 2004. Autologous platelet-rich plasma injection was first used in 1987 in open heart surgery. Today, PRP injection has been safely used in many fields like cosmetics, sports medicine, orthopedics, facial-maxillary urology. In hair thing, we have been using PRP for use in the hair loss, especially somebody coming to me, not a candidate for transplant, for hair loss, tried other things, then certainly I will try for PRP. Hair transplanted zone. I gave PRP before transplant, per surgery, during transplant, and afterwards. If patient, I planned for surgery, say for after 2 months' time, then one injection I will give at the 0 period, then after 2 months' time, surgery I can start. Even I have completed 3 doses with the interval of 2 months, then followed by the procedure and 1 injection per operator, and then it's my protocol to give another dose at the end of the year. And during surgery, I give PRP to the patient in an operating zone, the zone behind that where I find the vellus hair, and some PRP I mix with the grafts as well while placement. And sometimes if PRP is left, then I give to scar area as well. For larger areas, you have to harvest or get a good volume of the blood, even 30, 40 mils of the blood. So basically the components of the blood, 93% is the red blood cells, 6% is the platelets, 1% white blood cells, and then is the plasma, which is a liquid component. PRP, 94% platelet and plasma, and 5% is red blood cells. But that is limited in a very small zone. That's what we call buffy coat between red blood cells and the plasma. The PRP contains not only a high rich concentration of platelets, but also the full components of clotting factors and secretory proteins. The benefit of PRP is once the platelet degranulate, once the release of a growth factors and a lot of other factors from the alpha granules of the platelet. If we don't defragment the platelet, then it's not a factor. So usually I use a kit. It depends, how much harvest I'm getting. This is the smallest kit, where we get 8 mils or 10 mils of the blood and 4 or 4.5 mils of PRP. And if I go for larger, then I go for a kit with the 2 of the red bottles and 2 of the yellow bottles. Yellow bottles contains anticoagulant. We harvest the blood, take the blood from the patient, and then centrifuge it. As we finish the centrifuge, we shift the plasma into the red bottle. And there is a triggering factor, which is a platelet cell wall broken thing, is agent, is in form of in a drop or one or two drops, and then we shake the bottle to degranulate, the platelets, and then we quickly take it with a 10 ml syringe, and then transfer it in the smaller syringes with a 30 gauge needle. Beforehand, I apply EMLA. I don't give a nerve block to the patients, because nerve block itself is very painful. And the same pain you can create with a 30 gauge needle once we are inserting at different places. So I apply EMLA at least 20 to 25 minutes beforehand, and then quickly wipe it, clean it, and then insert it. Right. Doses. This is all my protocol, which I do for my patients. Slightly changed. Recently, I have done that. The first dose in hair transplant patient is once I'm doing at the time of the procedure. At the time of the procedure, as the procedure is about to finish, then we start to harvest the tissue and infiltrate it. Second dose is 1 month gap after the first, dose. And third is gap of, again, that's 1 month. And the patient who has thinning hair, vellus hair, because these are very good for the vellus hair as well. The first dose is a 0 period. Then second is I leave for at least 2 to 3 months' time. And then third accordingly. And I then see what is the result like. If the results are there, probably I will give a booster dose after a year. This is my protocol. This is not mentioned in any of the book. And what is the depth of injection we give? This is very important again, If you give subdermal, probably it's not going to affect. The platelet should reach, growth factor should reach absolutely at the bulb level. Why? Because these are going to work over there with the stem cells. I'll show you in a minute. This is one of the injection. While injecting in both of the areas, this is the transplanted zone, and this is a zone behind that. And we insert whole of the needle inside, but not hitting the bone. But certainly it's near the bulbar area of the grafts. Right. So this is, again, where we inject. We need to inject at the level of the, follicle. And if we inject it along with the alpha cell, the study reveals that, it's a study who carried out, I don't know, but picked from somewhere, that it displaces the DHT from the stem cells and progenitors. So that's one of the reasons that it gets a stimulus and is a growth. Right. I finish my topic over here. It is open for discussion.
Background is that the scalp alopecia is a leading cause of which we routinely deal. The most frequently patient comes with us post-burn scalp alopecia. Treatment of these large post-burn scalp alopecia constitute a real problem for the reconstructive surgeons. The psychological impact of such defects are quite traumatic, and their reconstruction proved to be a very difficult task, especially for the aesthetic point of view. As we reconstructive and plastic surgeons always strive for to reconstruct the things with like, to match like with like for the optimal aesthetic and functional outcomes. Different options of the scalp reconstructions are available, like rotational advancement flaps, hair transplantations, and tissue expansions. Tissue expansion is a widely used time-tested procedure to utilize the local tissue to replace the large defects. With the advent of the tissue expansion, there started a new era of aesthetic reconstruction of the scalp alopecia treatment. These are the different types of tissue expanders. So the aim of our study is to assess the results and complication in the correction of the post-burn scalp alopecia by using the tissue expanders. This study was conducted in Bahawal Victoria Hospital, Bahawalpur, from November 2010 to March 2015. We included 35 patients. Out of them, 14 are male and 21 are female. And average age was 18 years, and average stay in the hospital was 2 weeks. We prefer the rectangular expanders because it provides the additional expansion. Also, we use the round and crescent shape expanders. The surgical technique which we followed is that size of the expanders are range from 300 to 700 cc. If the defect exceeds 25% of the total surface area, then we use multiple expanders. And we preferred that incision of the insertion should be always perpendicular to the length of the area needed to be expanded, and that incision is always far away for the place of the tissue which is expanded. By using these two techniques, we take the advantage of immediate expansion postoperatively. And by repeated overfilling technique with normal saline twice weekly until the desired volume was reached, and with good preoperative plannings and by adding Z-plasties, we enable to cover the large defects and by avoiding the linear scars formation. And by rotating the flaps, we always consider that hair direction should match to the with the recipient side, especially while we reconstruct the frontal hairline and the sideburns. We followed the patient weekly for the first month and then fortnightly for the next 4 months, and we measure our results by seeing the major and minor complication and by the satisfaction of the patient. These are the results. 43 tissue expanders are used in the 35 patients. Out of them, we reconstruct whole scalp in 28 patients. And in 7 patients, we use transposition flaps to reconstruct the frontal and sideburns. We observed no major complication, while the minor complication are the hematoma, seroma, and cellulitis, which resolve with some sort of intervention like by using broad spectrum antibiotics. This patient, here in this patient, we see that the scar is very healthy, quite healthy. So in this patient, we use hair grafting so that hair transplantation is done for reconstruct the frontal hairline and sideburns. But in these types of the patients, when the scar is densely adherent to the underlying skin and is not healthy, we use the expanders. Multiple expanders are used, and these are expanded to obtain the desired results. And you can see here, the whole of the scarred skin is excised, and it is replaced by the healthy expanded flaps. This is the immediate post-operative result, and this is the late post-operative result of the patient. You can see the satisfaction over the face of the patient. And this is another patient in which badly adherent scar in the frontal and the parietal area. And we expanded the temporal areas with the 2 expanders. And we used the Jury transposition flaps to reconstruct the frontal hairline. And we obtained the satisfactory aesthetic results. This is another patient. We use single expanded, rounded expanders, and expand the whole remaining scalp and reconstruct the parietal and temporal alopecia. And these are the post-operative results. And this is another patient with the parietal and frontal alopecia. We expanded the remaining scalp, and we rotate and rotation transposition flaps are done. And these are the immediate postoperative and delayed postoperative results. Another patient with the satisfactory aesthetic results are obtained. Here we have the very minimal remaining scalp. We used the two expanders to expand the parietal area, temporal area, and we used the transposition fab in the frontal to reconstruct the frontal hairline and obtain the satisfactory aesthetic results. This is another patient with these post-operative results. So the conclusion of our study was that tissue expansion is a simple, safe, and effective technique for the aesthetic scalp reconstruction. With the simple modification of the distal incision of tunneling, we can start tissue expansion immediately with minimal complication. Versatile designs of the expanded scalp can distribute over the area to reconstruct the